Hi, my name is Jacqueline Theis, and I practice in Richmond, Virginia. I have a private practice that is called Virginia Neurooptometry, and I work specifically with patients who have vision problems in brain injury and other neurologic conditions. I had the pleasure this meeting of talking about multiple sclerosis, and multiple sclerosis is this wonderfully heterogeneous condition that is both autoimmune, neuroinflammatory, and neurodegenerative, which means that the visual system is actually impacted in multiple steps along the way. And so some of the key things that we talked about in the lecture was different ways that optic neuritis can present. We know that a lot of patients will present with optic neuritis as their first kind of manifesting sign of multiple sclerosis, and we also know that many of them can get better, but we talked a lot about how when they're getting better, they might still have, reduced contrast acuity, they might still have eye movement abnormalities, and then how to kind of treat that patient throughout the course of their condition, because after optic neuritis, and you send them for the workup and they get diagnosed with MS, you're going to have the wonderful issues of a lot of the drugs on the market can have ocular side effects, so you have to be able to monitor for those in patients. And then, of course, the disease is progressive, in which case then you're going to have either flare-ups in optic neuritis, or they can present with double vision from an INO, or they can have nystagmus. And so we talked about the different courses that people can have and how different it can present and how important it is that as optometrists, we really make sure that we're following up with these people and that they're getting the resources they need. And they might not need us for something, they might need to work with other people. Usually when you're looking at optic neuritis, oftentimes it is in somebody, you're looking oftentimes at demographics, right? So you have an inflamed nerve, usually it's unilateral, can be bilateral, and it's usually not acute onset vision loss, but subacute. I think the harder part is sometimes that optic neuritis is posterior, and so when you're looking into the fundus, it looks fine, but they have reduced vision, they've got a scotoma, it could be arcuate. I think the hard part is they all present a little differently. I would say the hardest cases that I've seen haven't been the optic neuritis that presents with MS, it's been patients who present with double vision or double vision and abnormal ocular motility, and they're outside of the demographics I expect. So for example, maybe a male who presents with double vision, I oftentimes have a different differential, and then I send for an MRI and I get surprised when it ends up being multiple sclerosis. So I think that's the harder part, is everyone's a little bit different in their presentation. So some of the really exciting research coming out right now when we're looking at visual fatigue is that visual fatigue can oftentimes be in a regular ocular motor system. And so we know that there are patients who have abnormal eye movements, nystagmus, oscillopsia, and that can cause a lot of visual fatigue. And I always say that you can tell those patients for a couple of reasons, but one of them is if I give you glasses, I'm not going to fix your cognitive fatigue, but if I give you glasses or I help minimize your nystagmus and all of a sudden you feel like you're not as tired, that's visual fatigue. And we don't give enough credit to how fixational abnormalities like nystagmus and saccadic intrusions can cause visual fatigue for patients, and how things like sending to low vision, making things bigger, using tints, a lot of these patients are photophobic, things like that can really reduce some of the extra fatigue that they're getting from their visual system just not being normal. There is no typical course. I think it's really understanding where the patient is in their journey of their multiple sclerosis, whether it's what treatment they're on or if they just got diagnosed. As the disease progresses and they start to lose their ability to be as mobile as they used to be, they're going to be more dependent on their visual system. And so, I've had patients where they're in a gurney and their joy is to be able to read or to be able to write something on a book, and recognizing that if you're in a gurney or a wheelchair, those working distances are going to be different. Putting someone on a progressive is very inappropriate if they have mobility challenges. So giving them what they need to empower them to do what they want is a wonderful part of optometric care. And it's just really neat to be able to work with them. And the other big one for me is recognizing, what are the things that you struggle with? That's a question I ask. What do you struggle with visually? And sometimes they'll say something and I recognize that's not visual at all, that's cognitive. And then maybe I'll send them to a cognitive OT or a social worker or someone else to help them figure out how to get, neuropsych for testing, obviously, but a lot of times occupational therapy can be helpful to go in into their home and help them move things around to make their life a little bit better. So I think there's also a big part of our profession to referring to other providers. One of the things about multiple sclerosis is of all the neurodegenerative diseases, it actually has the biggest pipeline. I think part of that's because it's the one neurodegenerative disease that really hits younger people. And so because of that, there's just a lot of backing behind it. And I think optometry is going to really be playing a bigger role in helping some of these patients as we have these drugs coming down the pipeline that help with not only disease management, but disease modifying therapy, possible potential for remyelination of the nerve. So really keeping our eyes open to the new treatments that are coming down the pipeline for MS will be exciting.